Hey everyone, and welcome to This Explainer. Look, if staring at the 2025 AHA-ACLS algorithms feels kind of like trying to decode a wiring diagram for a spaceship, you are definitely not alone. It's a lot. But today, we're going to demystify these life-saving protocols together, step by step. Okay, let's dive right into our roadmap. We've got 5 stops today. 1, the chain and bradycardia. 2, tachycardia, the fast heart. 3, cardiac arrest, which is basically boss level. 4, special cases, specifically pregnancy and ELVAD. And 5, post-arrest and team dynamics. First up is the big picture. The 2025 update actually brings a massive, honestly refreshing simplification. There is only one chain that rules them all. The AHA completely ditched those separate confusing chains for adults versus kids or in-hospital versus out-of-hospital. Now, we just have one unified pathway. It totally streamlines our focus on advanced resuscitation. Section 1, the chain and bradycardia. So the absolute most crucial starting point for bradycardia is asking one simple question. Is the patient stable or unstable? This is literally the fork in the road. A low heart rate, say under 50 beats per minute, isn't automatically a crisis on its own. There are plenty of elite marathon runners out there with resting heart rates in the 40s who feel totally fine. The answer to this stable or unstable question dictates our entire next move. The guidelines give us a very specific greatest hits list to define if a patient is unstable. If they're stable, it's easy. Just monitor them, support the airway, grab a 12-lead ECG, and keep a close eye on them. But if they're showing the signs on the right, we're talking hypotension, acute mental status changes, signs of shock, ischemic chest pain, or acute heart failure, well, their organs are starving for oxygen. We have to act right now. And when it's time to act for unstable bradycardia, we open up our pharmacology toolkit. Atropine is our absolute first line of defense. We push 1 milligram rapidly, and we can repeat that every 3 to 5 minutes up to a max of 3 milligrams. Think of atropine as telling the vagus nerve to just back off. It's great for upper heart blocks, but if you're dealing with a lower conduction block, like a complete third-degree block, atropine is just going to shrug at you. It won't work. That's exactly when we escalate to titrated infusions of dopamine or epinephrine to manually force that heart to beat faster and squeeze harder. Now, please listen closely to this part because it is absolutely critical. Dopamine and epinephrine for bradycardia are infusions. We do not ever give these IV push, okay? You have to carefully dial them up or down based on how the patient responds. Slamming the patient with an IV push bolus of these can instantly turn a slow heart into a much deadlier rhythm. Section 2, tachycardia, the fast heart. All right, shifting gears to tachyarrhythmias, heart rates at or above 150 beats per minute. We ask that exact same crucial question, stable or unstable. And this perfectly illustrates the golden rule. Unstable shocks, stable thinks. If they're unstable, we go straight to synchronized cardioversion. This is a brilliant, smart shock that syncs perfectly with the patient's R wave, so it doesn't accidentally fire during the heart's vulnerable moment and trigger something worse. For 2025, the guidelines lean heavily into going big enough to make it work the very first time. We're talking 200 joules for AFib and 100 joules for narrow complex tachycardia. Oh, and quick tip, if they are conscious, please sedate them first. Cardioversion while awake is a deeply unpleasant experience. Now, if the patient is stable, take a breath. We have the luxury of time to think and use medications. For regular, narrow complex rhythms, adenosine is basically the dramatic personality of the crash cart. You push 6 milligrams as fast as humanly possible. What it does is briefly hit the pause button on the AV node. This causes a terrifying few seconds of flat line on the monitor before the heart reboots. Seriously, warn your patient about that impending feeling of doom. Then, for stable, wide complex rhythms, we reach for our Swiss Army knife, amiodarone, which is infused slowly over 10 minutes, or procainamide. Just remember to stop that one immediately if the QRS widens or their blood pressure tanks. Section 3, cardiac arrest, boss level. Take a deep breath with me, because entering the megacode is high stakes. But honestly, everything hinges on one repetitive question. Is the rhythm shockable? Answering yes or no here splits the entire algorithm into 2 totally distinct lanes. Let's break down those 2 lanes. In the shockable lane, we've got VFib and pulseless VTAC. These rhythms respond to electricity. The pattern is shock, CPR, shock, CPR. But catch this, 2025 nuance. In the shockable lane, defibrillation comes first, and you only push epinephrine after that initial shock hasn't done its job. Now compare that to the non-shockable lane, asystole and PEA. Electricity will do absolutely nothing here. Instead, you need high-quality CPR and epinephrine pushed as soon as humanly possible. Of course, underpinning both of those lanes is the absolute foundation of survival, high-quality CPR. These steps are non-negotiable. Push hard, meaning at least 2 inches deep. Push fast, right in that 100 to 120 per minute sweet spot. Allow for full chest recoil, minimize your interruptions, and crucially, swap compressors every 2 minutes. Tired arms give weak compressions, and weak compressions just ruin blood flow to the brain. Now, while you're doing CPR, you also have to be a clinical detective. You're hunting for the reversible causes, famously known as the H's and T's. Hypovolemia, hypoxia, hydrogen ions, toxins, thrombosis, the list goes on. Why does this matter? Well, you can shock a patient and push epi all day long, but if they have, say, a giant tension pneumothorax squishing their heart, nothing you do is going to work until you fix that specific underlying problem. Section 4. Special cases, pregnancy, and ELVDAD. First up in our special cases is the patient with an LVAD, a mechanical pump that assists the heart. This is a bit of a brain bender. Because the pump pushes blood continuously, these patients typically do not have a palpable pulse. And actually, that's entirely normal. So, you do not just jump on their chest and start compressions because you can't feel a pulse. Instead, you ask, is their perfusion adequate? If their mean arterial pressure is above 50 and their end-tidal CO2 is above 20, they are perfusing just fine. Do not do chest compressions. Hunt for another cause for their unresponsiveness. You only start compressions if that perfusion is inadequate. Our second special case is cardiac arrest in pregnancy, where you're literally treating 2 patients at once. The fundamental CPR rules stay the same, but with some absolutely vital additions. First, you must perform continuous left lateral uterine displacement. This physically moves the uterus off the big vein so blood can actually get back to the heart during compressions. Also, place your IVs above the diaphragm so your meds don't get trapped below your compressions. If she's on a magnesium drip, stop it immediately and give calcium. Detach any fetal monitors before you shock. And remember, if there's no pulse back within 5 minutes, prepare for a resuscitative delivery. It relieves the vascular pressure and gives both mom and baby the absolute best shot. Section 5. Post-arrest and team dynamics. Look, getting a pulse back is huge, right? But return of spontaneous circulation, or ROSC, is honestly just halftime. The real recovery work starts right now in the post-cardiac arrest algorithm. Let's look at this massive 2025 update, the number 65. We no longer target arbitrary systolic blood pressure numbers for post-arrest patients. Scratch that completely. Instead, our sole focus for hemodynamics is ensuring the mean arterial pressure, the MAP, stays at or above 65. If it drops below 65, the brain and organs simply aren't getting what they need to heal. The second major post-arrest target is temperature control for patients who aren't following commands. The 2025 guidelines have officially shifted away from deep freezing the patient. Now, the goal is maintaining a very deliberate, specific temperature range, right between 32 and 37.5 degrees Celsius, for at least 36 hours. The focus now is actively preventing brain cooking fevers, which can absolutely devastate a neurological system that's already injured. Let's see how this all builds into our ABCDE primary survey for post-arrest. For airway, we secure it using waveform capnography. For breathing, we're actually titrating oxygen down to 90 to 98%, because giving too much oxygen causes real harm. Circulation, here's a huge 2025 shift. A peripheral IV is now officially preferred over an IO line. For disability, we run a quick AVPU neurocheck. And finally, exposure. You literally have to remove their clothing to look for trauma, burns, or medical alert clues. You can't treat what you can't see. Finally, beyond all the drugs and the jewels, the guidelines make it super clear that nothing functions without exceptional team dynamics. You've got to know your lane. If you get handed a task outside your comfort zone or scope, speaking up and asking for a different role is a sign of ultimate professionalism, not weakness. And always use closed-loop communication. If you're told to give 1 milligram of epi, you reply, giving 1 milligram of epi. 1 milligram of epi is in. That ensures total, undeniable clarity in a very chaotic room. And that brings us to the ultimate question. The algorithms and medications we just covered are incredibly powerful tools, but they require a confident professional to wield them. So, do you have the courage to know your lane, speak up clearly, and save a life? I really hope this explainer has left you feeling empowered, focused, and totally ready to dominate your ACLS certification. Thanks so much for learning with me today, and I'll catch you next time.